CD4 T cells, no CD8 T cells, no IgM. But after transplantation, slowly the cell numbers increased, and with the time also immunoglobulins appeared, and this patient survived very well for many, many years, of course. Sometimes it keeps for life. Another combination of disorders where immunodeficiency is just one part is the so-called Wiskott-Aldrich syndrome. With the time, they start with an eczema, they have lymphoma, they have autoimmune disorders. So they have many, many diseases to start it with, and only later immunoglobulin levels go down and down and down and down. Why? Because there's a certain molecule missing, which is very important for the cytoskeleton, the so-called protein CD43, and this is also recognized in these cells, where you have the patient on the upper side and the control lower, and you can see here you have a strong signal which is not here, and here you have a strong signal which is not here. So another opportunity for cytochromatic analysis to recognize this patient. Now coming to the next very important cell, which is the monocyte or the granulocyte, so altogether called the phagocyte. And just now grabbing some hawkeye here with their tentacles here, that they are engulfed into the cell. And usually this is just some background. Such a monocyte, which is here, can recognize a pathogen like here the Streptococcus as an example, with many, many different molecules, so-called pattern recognition molecules like tolerant receptors and complement receptors and immunoglobulin receptors. So there are many possibilities how a pathogen can be recognized by a phagocyte. And then, of course, it's the phagocytosis, and what's even more important than the production of oxygen radicals, so-called oxidative burst, for killing of these pathogens, and of course for cleaving all the antigens to be presented by MHC molecules to T cells or B cells. So here you can also see how is the response to pathogens by granulocytes. You have here the bacterial infection, here you have the bloodstream, and what you can see is that the neutrophils are merging there, and then they are killing the cell, and so then they are engulfed, and then they are killed by oxygen radicals. And maybe I can show you another moving. And this even has some music, if you can hear. But I don't know if it works. Oh, yeah. This is a granulocyte, which is one after the other of these bacteria. Now it is successful. I don't know if you know this music from James Bond. So this is the action of neutrophils. Many things can be disturbed in neutrophils and monocytes, and we have different forms of phagocyte deficiencies. We have the CGD, chronic granulomatous disease, leukocyte adhesion deficiency, also very severe Terry-Higashi, and so on, some more forms. And what happens in this, after the phagocytosis occurs, you have a phagosome and a lysosome, and they melt together and they give the so-called phagolysosome, and inside you have destructive enzymes, and you have oxygen radicals, toxic oxygen radicals, and these radicals have to be produced by a certain metabolism which includes NADPH oxidase, and then it goes down to superoxide dismutase to get hydrogen peroxide or hypochloronic acid. These are the very important molecules for killing bacteria and even viruses and parasites. And if they are missing, you have a disease like here septic granulomatosis, or in this case, the so-called pyroperoxidase deficiency. This is a very severe case of septic granulomatosis, So a lot of, they have pneumonia, they have abscesses, and they're very, very severe. And I think the only therapy option first you can give, of course, antibiotics, but which will not help very long. You can give gamma interferon, but these patients usually need a stem cell transplantation. So coming to what can we do for phagocyte analysis, actually it's not so difficult. There are chemotaxis assays, so looking if they are able to move. There are phagocytosis assays and assays for intracellular killing. And the so-called nitro-blue tetrasodium assay, it's a very simple assay which we can actually perform in each laboratory. You need a microscope and you do this thing, and you separate the cells from the patient and from the control, and you add to this particles. It may be candigal, it may be even latex particles, something which they phagocytize, and you add the dye, tetrasodium NPT, and in a normal case, in a control, you have a nice phagocytosis and a transition of the light blue color to a dark blue color. This is very important. So this indicates everything is working fine, as it should be in the control. And this patient was able to do the phagocytosis well, but there was no intracellular killing because there was no production of toxic oxygen radicals, and this can be recognized here in this kind of patient. So it's actually quite simple to do this assay, and you don't need high sophisticated assay. But of course you can do more sophisticated. You can look in cytophromatometric analysis again. You look with another molecule which is called dihydrorhodamine, which is also then activated. And what you can see here, the father was he was healthy. He has no deficiency, but the mother was a carrier, and this is the patient which has actually no function, no production of oxygen radicals. These oxygen radicals, they activate this rhodamine, that you get a nice fluorescent signal. Another very severe, unfortunately very rare disease is the leukocyte adhesion deficiency. You know, leukocytes, if they migrate to the place of infection, they are usually, most of them are inside the blood vessel. How do they get out? They have to get a signal on the layer, on the endothelial layer of this vessel, in the proximity of the infection. So like little antennas on this vascular endothelial cells, the so-called adhesion molecules. And their partners, molecules, their ligands are on granulocytes. So the granulocytes are attracted, and then they see this antennas, this receptors, this adhesion molecule, they attach to them, they roll on the surface, and then they migrate between the cells of the vascular endothelial space into the tissue to kill the microbe. And these patients, they do have granulocytes. They are very well functional. They would phagocytize immediately, they would kill the bacteria, but they are not able to migrate out into the tissue because they do not recognize these molecules, because the molecules are not existing. So this is a very severe disease, and you can see a lot of abscessa, and usually these patients die if they are not treated with stem cell treatment. And again, you can look here for the missing molecule, which is so-called CD18 molecule, expression on different cells. Here we have the control, we have the patient here, and as you can easily see here, the more you are on the right, the more present, the more expression. The more you are on the left, the less you have. So the control is fine, but the patient has much less. And also in lymphocytes, the signal is strong in control, but it's very, very weak in the patient. So this is easy to recognize. Another severe disease in combination is the so-called geriatric syndrome. The patients have a partial albinism, so hypopigmentism, but they also have sometimes severe neurological symptoms. They have a deficiency of phagocytosis and of intracellular killing, and the cells cannot move. They have very huge intracellular granula, which are typical for this kind of disease. And they have a deficiency of in a gene which has been called Chidiac-Higashi syndrome 1 gene, or the lysosomal protein regulator, which is very important that the lysosomal proteins and the lysosomes, that they are not only confluencing with the phagosome, but they are also released, and that they can do the intracellular killing. Now finally, the last part of the immune system is the complement system. Not many people know a lot about complement. And actually this is a very old picture. Those of you, I don't know, who have attended my last lecture here many years ago, 3 years ago, I've shown this. This is 100 years ago, a very famous German medical doctor and researcher, Paul Ehrlich. He described the complement system as one molecule which attaches to an antibody and which has a toxic group. So it complements the action of antibodies. But nowadays we know that this complement system is a huge system, a protein cascade system with more than 35 molecules in a cascade-like reaction as receptors, as regulators. And just principally there are 3 pathways of activation: the classical pathway, the alternative pathway, the lectin pathway, some molecules which recognize pathogens, and then they lead to the activation of C3 with the C3P molecule, and then which leads to the opsonization, that means a beta-phagocytosis, and then also some stick products, C5A, which leads to inflammation, and then finally the membrane attack complex is formed, and then you have a hole in the membrane of a pathogen, and this is called the membrane attack complex. So this is the complement system with many different molecules in a very simplified way. And you see here on the cell surface, you have the hole here, and this destroys the cell and the pathogen. And there's a huge clinical diversity of complement deficiencies. If you have any deficiency, then you have recurrent infection, very often with pneumococcus. If you have a deficiency of the classical pathway, interestingly, you have a strong association, a very high risk to develop an autoimmune disease, like systemic lupus erythematosus. If you have a deficiency of the late component of complement, you often have Neisseria meningitis. So every patient who is older than 10 years and has a meningitis, he may have a complement deficiency of these components. This needs to be recognized. And there are also some other deficiencies of regulators which are associated to a very severe form of nephritis, like the hemolytic uremic syndrome. How is diagnosis done? Just a kind of repetition. T cells, we have to do T cell surface marker analysis of T cell function. You can look for T cell proliferation to activate T cells with so-called mitogens. You can also do it with antigen. And then you look if they are able to multiply, to proliferate, or if they release certain cytokines, if they can do killing. There are certain functional assays. B cells, it's the same. You, of course, primarily do the immunoglobulin analysis. You do the serum electrophoresis first, and then the immunoglobulin analysis either by nephelometry or by ELISA. And phagocytes, I showed you the assay for phagocytosis, chemotaxis, or also phagocyte surface markers. And complement, you have to do the full complement function, it's called CH50. And then if there's no function, then you look closer to individual proteins. We recently published a paper on how to detect a patient for primary immunodeficiency. This is actually a paper for general practitioner, but actually for all doctors and also researchers. And this was published just recently last year in Clinical Experimental Immunology. This is a multiple author paper from the European Society of Immunodeficiency with many members. And the first author is Esther de Vries from Holland. And we contributed here with complement deficiency. And this is really a paper which you should have, because it's everything is step by step shown, how you can recognize which kind of diagnosis you can do. It's really, I think it's really a very important paper. So, last but not least, and very short, what can we do for therapy? And this is, of course, very important. On the other side, unfortunately, it's very expensive. Of course, you can do a treatment with antibiotics, and this may help for a while. You should look that the patient is not exposed to infection, which is not so easy in some parts of the world. But then you have to do substitution therapy. And the therapy of choice is actually immunoglobulins. This is a high dose of immunoglobulin, mostly IgG, which is purified from serum of thousands of blood donors, so they have really the reactivity towards all kind of possible pathogens, and this is given every 3 to 4 weeks at a certain dosage. You can give it IV, or you can do it subcutaneously, and you can train the patient that they can do it by themselves. If it comes to very severe forms of T-cell, severe combined immunodeficiency, phagocyte deficiency, then you have to do bone marrow or stem cell transplantation. We are still working on gene therapy, but it's still not really finished, and it has some risk factors like causing cancer, lymphoproliferation, and so on. It may take another couple of years until we have a good gene therapy. What is very important, and you have really to memorize this, if you have a patient who is suspicious of primary immunodeficiency, you are not allowed to give the patient the live vaccine, because the patient may have severe side effects and may die from this live vaccination. It doesn't matter if they are complement deficiency, then you may do it, but if you have a T-cell or B-cell deficiency, then you are at risk to lose the patient. So that's it, and this is my home city, Heidelberg. This is the old part. It's a very small city compared to Khartoum. It only has 140,000 inhabitants, but 35,000 students. So every fourth is a young student. As Professor Nazer mentioned, the oldest university. We do have the German National Cancer Facility, the European Molecular Biology Laboratory, 5 Max Planck Institutes, a big university. So nowadays in Germany it's a center of biomedical research. And as you can see, it's actually, this is our old castle. It's only some ruins because the French, who are now our friends, but many years before they were not our friends, they destroyed it. And so it's a really pleasant place to live, and this is a very small river compared to the Nile, of course. It's a so-called Neckarine. So, I thank you very much for your attention. Shukran. So, if you have questions, now is the time to ask questions. Please.
At the beginning of your lecture, at the beginning...
Everybody needs to hear the question.
Okay. At the beginning of your lecture, you mentioned that those diseases, as older you get, it's highly likely for you to get an immunodeficiency. But most of the pictures you showed were kids. So are those diseases more inherited than acquired with an age?
All right. You're right. Still, those cases which I have described, of course, most of the PID cases are still young children. But they are not only young children. The only thing which I wanted to mention is that you have to be aware that there may be in later age, you may recognize some patients, especially with common variable immunodeficiency, who have a primary immunodeficiency. And of course, you're also right, in later age, the situation is more, you have more forms of acquired immunodeficiency. But it's not exclusive for primary immunodeficiency that you have them as children. But let's say in 85% or 90%, you will recognize this patient already in an early childhood. But general practitioners and internal medicine persons, they also have to be aware that in their office, there may be some patients who have a primary immunodeficiency. More questions?
Thank you. Actually, it's not a question. I am having a comment. At the last of your session, that we shouldn't give a vaccine in order not to make the patient in risk of having immune deficiency. But actually, here we have vaccination start from the maybe 14 days of life. How can we avoid putting our children at the over risk such crime?
I think this is a very good question. The question points to the fact that if you have a suspicion of a primary immunodeficiency, but maybe you are not so sure, if there's a risk if you vaccinate your child. I think you should vaccinate it anyhow. If you are not clear about the primary immunodeficiency, then of course you have to vaccinate. Because you have to consider, although I was talking about many cases here, it's still, thanks God, it's a very rare disease. Yeah? Only very few. It may be a bit more in some regions of the world where you have consanguinity, where you have, let's say, a high rate of infectious disease, which may give you a suspicion that there may be a higher frequency of immunodeficiency. But in general, I would say it's so important to vaccinate the children that you should not stay away from this, because you may think it may be a primary immunodeficiency. And even then, there are a couple of primary immunodeficiencies where you have no side effects. It's only a general thinking that once you have a very established diagnosis, then you have to be very careful. So, more questions here.
What is called primary immunodeficiency? And what is the primary immunodeficiency and IgA deficiency? Why IgA found in the body small amount? Why is most commonly primary deficiency?
Why? I don't know. They are only speculation, because it's probably the most common form of the so-called immune dysregulation, because IgA deficiency is also very often associated with autoimmune disorders. And the reason is not known. It may be even an infection, a viral infection, which disturbs, or it may be, I don't know. It's really, we do not know. We only have it as a kind of fact, and we have to accept it. But why IgA is the most common form, I don't know. Maybe another explanation why it's so more common. The most common form, maybe it's not severe. Most of the people who have an IgA deficiency, they have no clinical symptoms, even a lifelong. And so these patients did not die, so they could propagate their genes to the next in the family. So this defective gene was inherited over many generations, and since the patients did not die, it's still many patients who got this gene. If you have a gene which leads to a clinical situation which kills the patient, then the lineage of this family is gone. So there's no propagation, no inheritance, And maybe this is a kind of explanation. It's not a good one, I know, but we don't know.
Thank you for your interest topic. My question is about how to differentiate between immunodeficiency with high immunoglobulin mu, IgM, and monoclonal gammopathy, benign monoclonal gammopathy.
First, if you have globulinemia or non-hemoglobin, if you have an or high amount in this gammopathy, then you find also you find minor traces among. But the final diagnosis is done. You have to look on the surface of T cells and of the antigen-presenting cell. There's a molecule which is called CD40 and CD40 ligand. And this pair of molecules is very important for signaling. They are called co-stimulatory molecules. And these molecules are very important, not only the interaction of the receptor, the antigen receptor of the T cell and the antigen-presenting cell, but a couple of other molecules which interact. And for this, the CD40 and CD40 ligand molecule is very important, and this is easily recognized by cytochromatic analysis. And if this is missing, then you're fine. In addition, with maybe gammopathy in terms of lymphoproliferative disorders, we usually have much more B cells, which are not the case in IgM deficiency, hyper-IgM deficiency. Are there more questions? Oh, sorry.
My question is that if the treatment caused by bone marrow transplantation, how long it takes, and if it is occur, and if it's going to be for a long time, or?
That's a very good question. I don't know if everybody understood it. If you give a bone marrow transplantation, how long the effect, the therapeutic effect lasts. If you are lucky, it lasts. But you have to take precautions, and this is also dependent on the kind of, and you have to have a good compatibility between the donor and the recipient patients. So you have to do a HLA analysis, and you have to look at on all levels the compatibility is as best as possible. So if you have family members, the very best is of course if you have a twin. Yeah? But then if you have a brother, a sister, a mother, a father, then you can also have heterologists from other people, of course, because not every time the family is available. And then you have to do HLA, MHC analysis, because if there's no compatibility, then you may have a reaction of your own T cells to the donor cells, which is called, or the donor cells to your own T cells, which is called graft versus host reaction. And this may create a very severe inflammation in the loss of the engrafted transplantation, but maybe also killing the patient. So you have to do a proper analysis before you can give the stem cell transplantation. Are there more questions? Yeah.
How can an SLE syndrome be a type of primary immunodeficiency? How can an SLE syndrome become a type of primary immunodeficiency?
That's also very good, and it responds to a new development in our view of immunodeficiency. The question is, how can systemic lupus erythematosus, SLE, be immunodeficiency? Not in every case the SLE is an immunodeficiency, but the SLE is often associated with an immunodeficiency and most often with a complement deficiency. And the question is, of course, why? The reason is that complement is very important in regulating immune complexes and also in regulating apoptotic material. You know, when cells die for apoptosis, there's a lot of autoantigen material in the bloodstream. And T cell may recognize it and then may induce a reaction in terms of autoantibodies. So we may have an autoimmune response. The longer those autoantigens are in the circulation, the higher the risk is that you get an autoantibody. And complement looks with a C1q molecule, it binds to apoptotic material, and then it is very fast phagocytized. And if you have immune complexes, which actually induce a disease in lupus, you know, the immune complex mediated disease, then complement C3b, which opsonize immune complexes, and these immune complexes are carried by erythrocytes to the reticuloendothelial system in the liver and the spleen, and there the immune complexes are eliminated by phagocytosis. So for two reasons, complement is very important, the classical pathway for eliminating autoantigenic material and immune complexes. And if this is deficient, then the risk is very high to get a lupus. But the risk is higher. But only, I can't tell you exact numbers, but maybe only 30% or 40% of all lupus patients have a complement deficiency.
My question was if there is a study we do after several patients with primary immunodeficiency, if the patient if the patient is developing cancer.
I think this is an important question, how we handle these cases in Sudan or in other developing countries. I think nowadays there are two steps, and the one step is now done here. You have to introduce a diagnosis system, a basic diagnostic system. But then, of course, the next level would be, and what you have done until now, unfortunately restricted to those patients who can pay for it, that you can send the samples abroad to a laboratory in Saudi Arabia or to Europe or to United Kingdom or to United States, and then have a proper diagnosis done. And then with this diagnosis, you turn on, but then still the patient has to be treated. But I think this is the reason we are now sitting here together, that you have to start your own diagnosis. And I'm quite sure, let's say with the 10 most important and maybe simple methods, you can already recognize maybe 50 or 60 or even more % of these patients who have primary immunodeficiency. Still, there's a question how to treat these patients, which is not solved yet. So actually I can only support the health ministry to put money into the healthcare system to allow everybody to have a proper treatment. And this is not only due for primary immunodeficiency, but also for any kind of disease, because every country needs healthy people.